Hi, thanks for joining me at Student Nurses Success today. This particular video is going to cover some of the anatomy and physiology and basics of the neurological system. In addition, we're going to cover a brief overview of mechanisms of brain injury and the concept of increased intracranial pressure and manifestations related to that. Increased intracranial pressure is the main symptom you see in most neurological disorders. Remember, you can find a link to the maps in the comments section. Let's go ahead and get started. I think it's wise to first review the components of the central nervous system. The central nervous system is really divided into two main branches, the central nervous system, or the CNS, and the PNS, or the peripheral nervous system. The main difference between these is really the components and their function as far as sending messages. In the CNS, that includes the brain, the cortex, all the parts of the brain, as you see in this particular picture here, and the actual spinal cord. The PNS includes the spinal and cranial nerves. So it's all of the stuff in the periphery. What the PNS does is it takes signals that are made and transmitted from the brain and actually sends them out to all the locations in the body. Let's talk a little bit more about the brain and the spinal cord and the central nervous system. The CNS is protected by something called a blood-brain barrier. The blood-brain barrier is actually just a bunch of cells that are tight and close together. That tightness and closeness of them really makes it a barrier to anything getting through. So it works to keep certain pathogens away from the brain and also maybe some drugs and other toxins that could cross in. The central nervous system, like I said, includes the brain and the spinal cord. When we're talking about the brain itself, we have the cerebrum or the cortex, and these are the main portions of the brain. In this picture right here, it is the pink, yellow, green, and purple areas. The cerebrum contains the frontal lobe, the temporal lobe, the occipital lobe, and the parietal lobe. Within the cerebrum is the basal ganglia, and that is responsible for coordination and movement. And so, in some disorders, such as Parkinson's, there's an issue with the basal ganglia. Now, the diencephalon is kind of in the center, kind of deep in the brain, and it includes the thalamus and the hypothalamus. The diencephalon is responsible for regulating the autonomic nervous system and it helps relay signals. As you can see below, the autonomic nervous system actually falls under the peripheral nervous system heading. The cerebellum is in the back, and so that's this particular area right there. The cerebellum is responsible for movement and balance, and the brainstem, which is this blue piece here, regulates respiratory and cardiovascular function. So it kind of regulates respirations, blood pressure, and also helps with ensuring that there's a good heart rate. And then you have the spinal cord, and most people are pretty familiar with what the spinal cord does. It transmits messages up and down to the brain. The peripheral nervous system includes the spinal and cranial nerves, and these are kind of out in the periphery. The PNS transmits signals from the brain and the spinal cord out to the muscles and organs in the body. Within the peripheral nervous system is the autonomic nervous system, and the autonomic nervous system actually regulates involuntary process. It makes sure that you have heart rate, blood pressure, and respiratory rate regulated. Within the autonomic nervous system, you have the sympathetic, which speeds up everything and it mobilizes under stress. It includes norepinephrine as its transmitter. And you have the parasympathetic, which is kind of known for resting and digestion and bringing everything down to baseline, maintaining homeostasis, and it uses acetylcholine as its neurotransmitter. Let's look down here, and I have the list of the probably the more common or more prominent neurotransmitters. Neurotransmitters are chemicals, and that's how the body communicates. The neurotransmitters in the neurological system that we often refer to and talk about are glutamine, GABA, endorphins, serotonin, dopamine, norepinephrine, and epinephrine. So, in certain disorders, we may discuss how those neurotransmitters are altered. Let's go up and talk about mechanisms of brain injury. There's lots of things that can injure the brain. You can have trauma, such as in maybe a TBI. You can have a tumor, which would take up space in the brain and cause pressure and injure the brain. You can have a stroke, and this picture here is kind of supposed to be representative of a stroke. In a stroke, what happens is as the blood flows through the brain, perhaps there is an area where there's a clot, and so that particular area of the brain actually necroses and dies. And so that's pretty representative of what happens in a stroke. You can also have metabolic problems. Maybe you cannot metabolize certain substances and they can build up and poison the brain. And also, the brain can degenerate, and there's a whole bunch of disorders related to degeneration. For the most part, mechanisms of brain injury lead to damage from, for the most part, two main things: hypoxia or ischemic injury, meaning oxygen doesn't get to a certain area of the brain, or there's an increased pressure, which can cause ischemia, hypoxia, and damage to the brain as well. So, we're actually going to talk a little bit more about both of these things and expand on them a bit. Let's talk about hypoxic and ischemic injury. Your brain really requires a lot of oxygen, and your body does a lot to make sure that you are getting enough blood supply to that brain. And in fact, it will shift blood supply from other areas of the body in order to make sure that your brain is getting enough oxygen through its blood supply. So, the problem with ischemia, if we have hypoxia or ischemia or lack of oxygen to a part of the brain or the whole brain itself, we will see immediate neurological dysfunction. Usually that's in the form of a change in level of consciousness, and that's usually our first sign that something is going wrong. Very quickly, what happens if the brain is not getting oxygen in an area, the mitochondria fail, ATP, ATP becomes depleted, and the cells actually stop functioning. They no longer pump. And so what we see is an accumulation of electrolytes in the cell, and the cell will die. And this happens pretty quickly. We also know that sometimes an injury to the brain can cause swelling. We know the inflammatory process results in swelling. This swelling puts pressure on the brain and it can compress the brain, decreasing blood flow, causing ischemia as well. Now, the body does do a couple things to try to compensate and make sure that you're getting enough oxygen to that brain. When we are hypoxic and CO2 levels rise in our body, the body knows that the brain's not going to get enough oxygen because you're hypoxic and there's not enough there. So that rise in CO2 actually causes vasodilation of the cerebral vessels to try to get more blood up there and to get as much oxygen up there as it can. Likewise, with hyperventilation or when your CO2 levels drop, we start to see a little bit of vasoconstriction of those cerebral vessels. Now, we also know that a decrease in intracranial pressure also happens when we vasoconstrict. So, we might be able to, in brain injury, actually alter respiratory rate in order to kind of reduce swelling in the brain. So, when we do have increased intracranial pressure, we could hyperventilate our patient and it does decrease the swelling. However, it may also cause decreased oxygen to get to the brain. So sometimes that results in more trouble. We also know hypothermia decreases brain metabolism, slows down brain functions, and can conserve some oxygen. And that can be protective against ischemic injury as well. So sometimes we can use ventilation to decrease intracranial pressure in the brain. Or we can use decreased temperatures or hypothermia to decrease intracranial pressure in the brain as well. Now let's talk a little bit more about this increased intracranial pressure. Increased intracranial pressure is when the contents inside the skull are under pressure. So think about this. Inside your skull, you have your brain or your cortex, you have cerebrospinal fluid, and you have blood. Those all equal 100%. The problem is a change in any one of these requires a change in the other. So if you have brain swelling because you've injured your brain, then we have to decrease either blood flow or cerebrospinal fluid. If you make too much cerebrospinal fluid because you have something like hydrocephalus, we have to decrease either blood supply or do something, or the brain is going to be squished. If you have blood accumulating in your brain, as you see maybe down here, you can see it starts to squish the actual cerebrum and can cause brain dysfunction and will also decrease blood flow within that cortex. So just remember that any change in one of these, brain, cerebrospinal fluid, or blood, is going to have to result in a change of the other. There's just no room. And that's what causes increased intracranial pressure. So with brain injury, we see brain swelling increasing ICP. With infection or hydrocephalus, we might see an increase in cerebrospinal fluid. If we're having a bleed or a hematoma, we're going to have to see a change in blood flow as well. The skull makes this all a closed system with the only outlet right here at the brainstem. So as this pressure starts to increase and we have brain swelling or increase in blood supply, what's going to happen eventually is that pressure is going to build within the cranium or the skull, and we can actually herniate our brainstem and have brain tissue that goes down through that only opening. So compression of the brain is going to result in increased intracranial pressure and possibly the herniation of the brain down the brainstem. In this particular case, this is going to cause death and mortality. Let's talk about manifestations of intracranial pressure. Um, these are pretty common, and we'll see these with almost all neurological dysfunction. So it's important that you kind of get these down. The very first sign you're going to see as intracranial pressure increases is a change of level of consciousness. This can range from just mild confusion to even a full coma. So if you have a concussion where you bump your head, you might have such mild brain swelling that you're not even going to see much of anything. You might be a little tired, or you might be maybe have some altered consciousness, maybe for a short period of time. So this can range. Now, if you have a severe head injury and you have severe swelling in that brain, then you're going to probably see a huge change in level of consciousness, maybe even down to coma. The next thing you're going to see is altered motor. You may see seizures, or you can see posturing. Decorticate posturing, which is flexion, where everything kind of draws in, or decerebrate posturing, where there's extension of the arms and legs. Now, decorticate posturing is really damage, showing damage to the cortex. Decerebrate posturing is really showing damage to the cerebellum and the brainstem. So it's much more problematic. This altered motor, again, is from the squishing of the brain, from the increased intracranial pressure, and it pushes on the motor centers. Patients often experience headache. They can have visual changes from pressure on the vision center of the brain. They can have vomiting. In severe cases, when we really have really high intracranial pressure, we can see the development of Cushing's triad. Cushing's triad is a widening of the pulse pressure. So we'll see maybe a blood pressure that's kind of bizarre looking, like maybe 150 over something like 40. And so you see this really wide pulse pressure difference between the two. You'll see a decrease in the heart rate, bradycardia, and an alteration in the respiratory rate. This is because of pressure on the brainstem. And when we start to see this Cushing's triad, we know that we are really high on that pressure and we could herniate that brainstem. That would be the same with this posturing. When we really get down to this decerebrate posturing, we're putting lots of pressure on that brainstem. We often in the clinical setting use something called a Glasgow Coma Scale, or GCS. The Glasgow Coma Scale is a rating scale where we rate or grade eyes opening, motor responses, and response to pain. And we grade these by giving them numbers, and then we transfer it to a kind of a key that tells us if we have a Glasgow Coma Scale rating of greater than 12, then we're really having mild manifestations of increased intracranial pressure. Once we get 9 to 12, it's moderate, and once we get down 8 or less, it's severe. So the Glasgow Coma Scale is used in the clinical setting to just give us kind of a objective assessment of intracranial pressure. And there you go. We've gotten our basics of our neurological system down. Make sure you watch our video on neurological disorders where we will cover stroke, we will cover seizures, we'll discuss infections and traumatic brain injury.